This video will cover chest tumors, chest traumas, and chest tubes. So let's talk about chest tumors, lung cancers in particular. Leading cause of cancer deaths for men and women, 80 to 90% related to cigarette smoking, with 3,000 deaths a year from secondhand smoke. There can be other types of exposure, so think about things like environmental exposures, occupational exposures, radon, which is an odorless, colorless gas that can be released into your home from the ground. So many times we have to check our homes for radon when we're selling or buying a home. Certain genetics can also impact and increase our risk factors. There's a box 10-11 in your book that talks about various risk factors for lung cancers. There are two types of categories of lung cancers. There's a table 10-4 in your book. There are the non-small cell lung cancers, which consist of squamous cell, adenocarcinoma, and large cell. And those are usually staged using the TNM, the tumor lymph node metastases process of staging. We also have small cell lung cancers. And what these can do is to develop what they call paraneoplastic syndromes, which means that the tumors can cause the secretion of various hormones, or the tumors can actually secrete hormones and cause hormonal imbalances. Things like ACTH can be abnormally elevated, leading to Cushing's. Too much antidiuretic hormone, too much follicle stimulating hormone, parathyroid or insulin. So small cell lung cancers can cause some very serious systemic complications that we need to work for and look for. Our assessment and diagnosis with lung cancers, we need to check things like their cough. Do they have a cough? Is it different from the cough that they had because maybe they've been a smoker for 40 years and they've always had a cough in the morning, but now it's more frequent, it's different, it's bringing up different types of sputum. Are they having increased shortness of breath, chest pain, more prone to developing respiratory conditions like pneumonia? Do they have something called pleural effusion, which is the accumulation of fluid in the pleural space between the two pleura in the chest cavity? Hoarseness, chronic hoarseness, can be an indication of lung or even throat cancer. So some of our diagnostic tests that we do for lung cancers, we send our sputum for cytology. Cytology is checking for cancerous cells. We can do a thoracentesis. We can remove that pleural effusion, that fluid from the pleural space, and send that for cytology, looking for cancer cells. We can do CAT scans, MRIs. We can do bronchoscopies, where there's a tube that goes down into the throat and into the lungs and visualizes where these tumors might be located, and sometimes even being able to take a biopsy of that tumor to determine whether it is malignant, what type of tumor it might be. We can use a mediastinoscopy, so go into the mediastinum where some tumors might be located and try to get a sample of that for diagnostics, and other types of biopsies that we can do. Now there's ways that we can treat and manage lung cancer. We can do surgery. We can remove a segment of the lung, segmentectomy. We can do a wedge resection, a more peripheral removal of the lung, of a section of the lung. We can do a lobectomy, a lobe of the lung, or we can do a pneumonectomy, the entire lung. So all of these, in many cases, are going to be open chest, very serious, involved surgeries. Although there are some types of video-assisted thoracoscopic surgeries where they go in using very small incisions to remove parts of the lung or the tumor. We can do radiation treatment, which can help to shrink the tumor so it's more easily removed, or it may be radiation alone because surgery cannot reach where that tumor is located. We have chemotherapy, particularly with small cell lung cancers, and that helps to shrink, again, the tumors and enable us to remove them, or to provide palliation, symptom relief. Shrinking the tumors will help to relieve some of the negative symptoms that the patients might have. And here's a picture of a lung tumor, and that whitish, blackish area up at the upper right-hand corner of the lung is, as you're looking at it, upper right-hand corner, upper left for the patient, is the tumor, and all those black spots there are the tar and nicotine from their long history of smoking. You can also, in the category of chest tumors, have what we call mediastinal tumors. So the mediastinum is that area in between your lungs where your heart, your aorta, your superior vena cava are located. So if there are pressures building up in the mediastinum, it's going to compress your heart, causing something called cardiac tamponade, where the heart is unable to expand and contract and pump blood effectively. It can compress your aorta, impeding the circulation of oxygenated blood from the left side of your heart. It can impact and compress your superior vena cava, causing what's called SVC syndrome, superior vena cava syndrome, fluid backing up into the neck and into the head. So the signs and symptoms are going to be related to the fact that fluid is not getting back to the right side of the heart, that's being compressed, or the aorta is being compressed, so we have poor perfusion, or we have actual physical compression of the heart, making it difficult for it to expand and contract and pump effectively. So our diagnostics are going to be our CAT scans, chest x-rays, MRIs, PET scans. All of these are going to help us locate the tumor, and hopefully we can remove it surgically or shrink it with chemo and radiation. Now we're going to move into chest traumas. And we have two categories of types of traumas that can happen with our chest. We have blunt and we have penetrating. So the blunt force traumas will happen when there is a severe impact to the chest, causing internal damage that oftentimes we can't see. We can't identify that this is going on, but we always want to look at what's bringing that patient in to present to us. What was the cause of their coming in with some chest discomfort, and looking for signs and symptoms of internal damage that is not necessarily present or visible from the outside. Or we can have penetrating chest traumas, gunshot wounds, stabbings, impalements, that sort of thing. So our assessment is very critical at this point. We need to find out how much time has elapsed since the trauma occurred, so that we can be looking for signs and symptoms of cardiac tamponade or pulmonary contusions, any kind of internal damage, and how that is going to start presenting to us in terms of changes in vital signs, ABGs, that sort of thing. We're going to be doing chest x-rays, obviously, to try to visualize what kind of trauma and damage could have occurred, CBC to check and see what kind of bleeding is going on, ABGs to make sure that we are breathing and exchanging gases effectively or not, clotting studies, electrolytes, typing and crossing. So we have to be very alert to the hidden traumas that can happen with our blunt traumas. Now, one of our results of blunt traumas can be something called flail chest, which can be the result of rib fractures. So the seriousness, the level of seriousness of rib fractures varies. We could just have a cracked rib. We could have several ribs cracked or broken off completely in one particular area. And that is what happens when we have something called flail chest. 3 or more adjacent ribs fractured in more than one location. And so the segment of ribs has basically disconnected from the rest of the rib cage. So it's, and I put in quotes there that it floats freely. It doesn't mean it's floating all over the chest wall, but it's moving independently from the rest of that rib cage. And we have what are called paradoxic chest movement, and that is a very significant sign of flail chest. What happens normally when you inhale, your rib cage expands, and when you exhale, your rib cage contracts. What happens with flail chest is that the flail segment is going to move in opposition to the rest of the rib cage. So when the rest of the rib cage is expanding with inspiration, the flail segment sinks in. When you exhale and the rest of the rib cage is contracting, that flail segment bulges out. So it's moving in opposition, paradoxic chest movement. So patients with fractured ribs, with flailed chest, can develop pulmonary contusions. This is a video that you can look at, and I will also play it in class when we get there. Pulmonary contusions are a bruising of the lung tissue, often associated with rib fractures, can often result in pneumonia or ARDS, and may require long-term ventilatory support. What we're doing now is something called rib fixation. So in your level 1 trauma facilities, oftentimes they will do something called rib fixation. So just like you have a pin and a screw and a plate and a rod or whatever you might have to stabilize fractures elsewhere in your body, they're doing that with rib fractures. What this does is significantly decreases the time that patients have to be on a ventilator. It helps them to recover much more quickly. In the past, patients with multiple rib fractures oftentimes would be permanently disabled by that. We would never be able to get them back to their prior level of functioning, and often were permanently disabled. This has much, much better outcomes with younger patients with fewer comorbidities. This rib fixation can basically get them back to their normal life. With elderly patients who normally their mortality rate increases significantly by percentages with each rib that's fractured. So the more fractured ribs, the higher their mortality rate. This significantly reduces the mortality rates in our elderly patients. So rib fixation may be something that you will see with your patients at the time of their trauma. Now, there are a couple of reasons why patients are going to need chest tubes. There is air in the pleural space, and that's called pneumothorax. We have two types of pneumothorax. We have the open pneumothorax and the closed pneumothorax. An open pneumothorax is also referred to by some practitioners as the sucking chest wound, because it makes a horrific sound because you have an opening in the chest wall and air is going from the atmosphere through this hole into the pleural space. And so it makes that sound, and I'll be playing a video of that in class to have you listen to a sucking chest wound. And so normally these pressures kind of equalize when you have a sucking chest wound, an open pneumothorax. We put in a chest tube, we get the air out of the pleural space, the lung heals, and everything re-expands and goes back to normal. You can also have a closed pneumothorax where the chest wall is intact, but there's an opening in either the lung or the airway where air is getting into that pleural space and causing the lung to collapse. And basically what it's doing is breaking that negative pressure, that vacuum that is holding that lung expanded and up against the chest wall. Patients with a closed pneumothorax are at particular risk for a very nasty complication if they're on a mechanical ventilator, because we are continually pushing air into that lung and it's leaking into and it's getting into that pleural space. A simple closed pneumothorax will equalize those pressures. A complication of that would be something called a tension pneumothorax, where the pressures do not equalize and air keeps building up and building up and building up in the pleural space and causing something called mediastinal shift. So the lung is collapsing, and I'll get to the, let me put you at the picture. The lung is collapsing, and there's air building up in this right side of the chest, collapsing the right lung, and it's going over and pushing into the mediastinum. That's called mediastinal shift. It's crushing the heart. It's also causing tracheal deviation. You can see the trachea here. Here is midline, and the trachea is deviated away from the midline towards the unaffected side. So it's all this pressure is push, 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 collapsing the lung, compressing the mediastinum, and causing the tracheal deviation. You can see it by looking at the patient. You can see that tracheal deviation if you look at them head on. So pressures are not equalizing. This is a critical emergency because we end up with cardiac tamponade, we end up with obstructive shock. The patient basically loses their ability to pump their heart, and they will be brain dead in a few minutes if we don't release this pressure in that right lung field and re-expand the lung and relieve that pressure on the mediastinum. So we do what is called a needle thoracostomy, and I gave you the link for that video, and I'll also show that video in class so we can talk about what's going on with that tension pneumothorax. Here's a sucking chest wound video that I will also play in class, and you can look at that. And then fluid in the pleural space. We have hemothorax, which is bloody fluid in the pleural space. That can happen after rib fractures as well. Or we can have pleural effusion, clear or cloudy liquid in the pleural space, which can result from lung cancers, renal failure, congestive heart failure. When we have pleural effusion, we will often do a thoracentesis to remove that fluid. And that will help to relieve that patient with their breathing issues. We're going to talk at length in class about chest tubes. Here's the video that I will be playing in class, but if you want to look at it earlier, feel free, and we'll have a more detailed discussion of how to manage chest tubes, how to set them up when we get to class.